Hi, how are you?
Hey.
Your mom's in 224?
Yes, 224B.
Okay. So my name's John. I'm the director of that unit upstairs.
Okay.
Um,
Are you the case manager?
no, I'm the director. I'm a nurse, but I'm the director of all the nurses that are up in that unit.
Okay.
I know mom's not doing well. I understand I know there has been some issues back and forth with, we can't have you reporting stuff. If you're coming into the hospital and stuff, you cannot be reporting stuff.
Okay.
You cannot be talking disrespectfully to staff. You cannot be judging staff what they're doing. We're here to do a job and to care for your mom the best we can.
I'm not here to do that.
And fulfill the wishes. But we have to have things done appropriate because we have other people here that are trying to get better as well.
Right, I'm not trying to cause any, scene or nothing like that.
Okay, let me go in and check on your mom.
Yeah.
And then I will come back down here. But like I said, you cannot be trying to record us and do things because that's also violating other people's rights that are here.
Okay. The situation was for me is that I was told I could have a visitation the other day as it was exemption and support, and I showed up on Sunday, and they wouldn't let me in.
Okay, I don't know about that. I know I was called late Saturday night regarding something. You were calling the house soup them over as well, and I told her to let her know that you've updated as best you can, but she has her, got to finish doing her job and take care of it.
And would you mind if I expressed to you what my concern was about her situation?
You can for sure do that.
So what happened is that the first day when I checked her and her oxygen levels were low, they were still above 70. They were in the 70s, and on the second day, they were up to 80s. They put the nasal oxygen on her. And on the third day, she was up to 90s. And then on the fourth day, and she was getting up and going to the bathroom regularly. And on the fourth day, the nurse Yoon just forced a bed pound on her without her permission. And she didn't allow her to get up and go to the bathroom. When she tried to get up to go to the bathroom, they started sedating her without her permission or my permission. And her situation's been getting worse and worse since then.
Okay, if your mom is of sound mind when things are happening, then we don't have to seek, obviously, your permission unless she tells us, oh, you need to check with my son.
She did when I checked into the hospital.
So if she's of sound mind and we're in doing things and caring for her, then we don't have to run things by you unless she's asking us.
She did ask me to when I was checked in.
And if she's getting up and going to a restroom, but a nurse does not feel it's safe for her to go to the restroom and needs her to go in a bedpan, that's within our nursing judgment, because we also have to make sure we're doing what's safe for our patients. So if we see them, like oxygen levels dropping as they get up and exert themselves, which is common with kind of what's going on with your mom, that could be an issue. So then we would say, no, you need to go to bedpan because we can't have you overexerting yourself and causing your levels to drop even more. If we don't feel it's safe for them to get up and go, we're concerned about them falling or something happening. Because also, how would you feel if we said, yeah, go up and get to the bathroom, she gets to go to the bathroom, she's weak, she falls and hits her head, and then gets like a bleed in her head?
I would have felt much better than them combining 3 different sedatives, giving him to her without her permission.
So looking at the sedatives, I would actually have to sit and look at her chart, because that sounds like that happened on Med 2, which is a different department from the one that I'm over. Because Yoon's not my nurse. I know Yoon. She's a Med 2 nurse. So I know your mom was in downstairs, then she went to ICU, and then she's been up in SDU.
Okay.
So I'm over ICU and SDU. So those 2 floors, I have to speak for those. Out there, I'd have to look at it, because I knew of your mom and her kind of case, but I didn't know enough to be tracking.
They have her on morphine, Ativan, and Precedex, all at the same time.
Some of that is done to control breathing. If she breathes too hard, too fast, we know that your mom was made a DNR DNI, so you guys didn't want us to put her on a ventilator, correct? So knowing that is happening, then we have to do things that we can do to get her breathing good without knowing that's not an option to go to. So not putting someone in a ventilator is 100% you guys is right, and that's totally fine. But then we're going to do everything in our power to control and regulate her breathing, because if she's breathing too hard, too fast, too quick, she won't sustain. So then you look at Precedex, stuff for pain, stuff to help her relax and control, so she's not working so hard. So that's why she was getting multiple different medications, because we were trying to regulate, and there's certain meds that we cannot give unless they're on a ventilator. So some higher medications that we could give to sedate and control the breathing, they have to be intubated by law for us to give.
Yeah, but that was supposed to be an option. Exactly, we didn't give them permission to do that.
Well, we didn't intubate. But I'm saying, like, there's other meds we can give. Like, some people with breathing issues, we give them paralytics. So basically, we paralyze them and we control the breathing, but you have to be on a ventilator to do that. And since she's not on a ventilator, we can't give those meds, which is totally fine that she was on the ventilator, but then that kind of narrows what meds and our choices that we have that we can use. So then we have to give the medications that we're allowed to use in the way that we can to try to help her breathing and control her breathing, because she was breathing too fast and too quick that she wasn't oxygenating. So we were trying to sedate her, make her comfortable, make her relaxed, so her breathing would relax, so she would do better.
Right.
So that's why it wasn't like we were trying to just over medicate her to give her meds. We were trying to give her meds so that we could get her to breathe and oxygenate better.
Right. And I'm very I don't understand why they were doing that. You know? I just don't understand.
Are you recording it?
No.
Okay. Well, we're trying to do that because we're trying to help her to breathe better.
Yeah. I don't get it though, because on the fourth day, their oxygen levels had improved. They were all the way in the 90s. And on the first day, they were in the 70s. So why did they choose to send her? And when I asked for the reason, they said because there was more nurses in the ICU. Why did they send her there? You know, they said because she was, you know, it went down to 76, which was higher than when she was checked in, and that was only because they weren't letting her get up from bed, and they had to sedate her.
Normal is over 92. Well, 92 is typically what we'd be going for.
Yeah.
So
it was past 92.
You and I sitting here talking should be 97, 98, no problem. Yeah, so she was low. There's certain treatments they cannot do on the floor that they can only do in the ICU. So then you would transfer somebody into the ICU because there's certain treatments they cannot do.
But her oxygen levels were like 95.
I would have to, like I say, I'd have to look fully in there at the time. I know Dr. Mulray has been following her and Dr. Pandia. They are both two great, very smart, knowledgeable physicians. Yeah. I would trust their judgment, but to look, it sounded like she was having periods of not breathing as well. And was she 95% on a couple liters, or is she 95% on high flow and a venting mask? And
she was only on the nasal oxygen, and she was talking to me on her cell phone, telling me everything.
But was it high flow or is it a regular nasal cannula? Because there's two different ones that go in your nose. And high flow, you can really dial up and give a lot of oxygen through. And if you're maxed out on that, then your next step is looking at BiPAP intubation. So if you're maxed out on high flow and you're wanting to do BiPAP and not intubate, then you're going to look at going to an ICU, because when you first start something like that on BiPAP, they want them usually in the ICU. And then giving her the Precedex and stuff to help her be more comfortable. BiPAP's not the most comfortable thing, so we try to make sure they're comfortable. So when you look at the clinical picture of everything that was happening, there's certain therapies that they're not allowed to do on the floor that only can be done in ICU or a step down. So then even though the patient may seem okay, oxygen okay, you move them over there because that's just what the nurses are trained to do.
Yeah, but I told them that the situation was improving. If they look at the records, like there's no reason to admit her to the ICU after 3 days. If they were going to do it, they should have done it the first day.
No, it depends on how the patient looks and how they're presenting clinically.
When the situation was improving.
Like I say, you'd have to look at the chart to see. Was she 95 and she was maxed out on high flow? When she came in, she was 70. We had room to work on titrating oxygen and things up, and that's
I understand how you expressed that could have been a concern about her falling and everything when the nurse was getting up to go to the bathroom, but that was still her right to be able to do that. She was able to communicate that very clearly.
There's things that, again, I have to look thoroughly through the chart too, because there are times sometimes you have to have orders so a patient can get up. And providing a bedpan versus getting up, some of that is patient safety. And that also is an issue that we have to take into effect.
If that was an issue, they were already letting her do it for more than 3 days, so then that would be an issue.
But is her clinic picture declining and she's struggling more?
It was increasing. Her situation was getting better. Her oxygen levels were steadily increasing over 3 days.
But again, you're talking about her oxygen levels, but are you knowing what she was needing to maintain those oxygen levels?
Yeah, it was the same. They didn't change the oxygen. It was started giving her the maximum nasal one.
So for that, I'd have to look at the chart to see, because the same nasal cannula stays in, but the machine is hooked up to. That's where we adjust the settings. So everything can look the same to you, but then you have to actually look to see what was documented to what what were they doing with the settings? Because your mom could be saying, yeah, I'm doing fine, I'm still on the high flow, but they could have been adjusting the settings, and she just may not have seen, because nothing would look different to her.
Right, and nobody
nothing
was
would look different to you as you're talking to her, or FaceTiming her, or talking on the phone. Nothing would look different, because it's all in the programming on the high flow machine.
And nobody was providing me with that information for some reason, right?
Well, if people asked for it, then you.
I did ask for everything when I would call. I would ask I would ask for a status and what's how is everything. I want to know everything that's happening, And they would here's all the notes. They told me here's all the notes, and they read the notes from the doctor.
Okay.
And it didn't provide me with all the information.
Okay. Like I said, I can't. It's hard to speak for that after the fact and after stuff's happened. But like I say, it's hard to know. You can think, oh yes, she's doing great, she's actually doing okay. But if we are moving up on her oxygen requirement is steadily increasing, then that would be a reason. If she's breathing too hard, too fast, and we needed to get her on some medicine to help her relax a little bit, then that is reason to justify going to an ICU. Even though you look like, oh, she's looking better, she's oxygenating better. I mean, maybe her stats were looking so strong, but she might have been working a lot harder to breathe. Her chest actually could have been looking worse. Her oxygen demand could have been getting higher. So those are all things you'd have to look at. But they don't just send people to the ICU.
How would her oxygen demand have been getting higher? Well, he's honestly the reason that they gave me when I was speaking with him on the phone. That Dr. Garber gave me was that she needed more, because I told him, when he said that her oxygen levels had only dropped to 76, and when she was admitted they were lower than that. So why did they admit her to the ICU when they were higher than when she was admitted to the emergency? And he told me the reason is because there's 4 nurses available in the ICU. And he said, well, there's only 4 nurses available, and there's only 2 in the room, in the house, wherever they had her in room 100.
Well, it could be a difference of if they want her watched a little more closely, because 4 nurses, their ratios are 4 patients to each nurse. In the ICU, it's a 2-to-1. So there's a little bit more. If somebody's a little more, they want to keep a close eye. I remember
that should have only been if she wanted it or needed it, though, but she didn't want it.
If she didn't want to go to the ICU, then you would make her comfort measures and say stop all treatments. But if you're saying,
I did do that.
If you're saying that just because somebody's a DNR doesn't mean we don't treat them.
Yeah, I spoke with the doctor and he refused when I said that, and then I spoke with the supervisor Sean and he also refused to do anything about it.
Well, unless you are 100% saying, like, I don't want anything done for my mom, I just want to make her comfortable, I'm going to either take her home or put her on like a morphine drip and then just make her comfortable and let nature take its course, then we do still treat. Because
I actually came down here with my neighbor Roxana, and we were both here, and I asked for the AMA for her to start the release, and they wouldn't give it to me.
Well, it's. I mean, you'd take her at AMA knowing that if she left, she probably wouldn't make it out of the building before she passed, because the whole oxygen she's requiring.
Right. Well, I would have another ambulance ready to get her, but yeah.
Well, they're not. You would have to do a transfer. You can't just sign somebody out AMA and have an ambulance. Like, that's not how it works. You just have you just call an ambulance and have them come pick her up. Because
just call 911 and have them come pick her up.
Okay, but if you call 911 outside of our hospital, they're going to bring her to our hospital, because 911 works to go to the closest facility. So if you're outside of our hospital, because we've had people discharged and something happens, they come right back in.
I also asked for the transfer to occur, but the doctor wasn't approving
of it.
Well,
transfer, you've got to have a clinical reason why you're transferring. For insurance to approve it, you have to have a receiving physician at the new facility, and the new facility has to agree to it, and insurance, because sometimes facilities go based upon insurance, where they're going. So if you're going to go to a place that's not a network, then they're going to look at you and be like, okay, well, this is not going to be covered. You're going to be potentially be on the hook for this bill because it's out of network, a bunch of benefits. Hospitals have to agree to receive. There's got to be, some justification in reasoning. Typically you transfer a patient to another facility, it's because of a need for higher level of care. Like, there's something that your mom needs that we can't provide, then you look at transfer to other facilities.
Basically just, it really doesn't make sense, the whole situation.
Okay.
Nothing about it really makes sense. It's just that's supposed to be a federal right,
What is a federal right?
To be presented with her options and given a choice. able to, to make the choice.
Well,
And if not, that I would be able to make the choice with her if the doctors decided that, that she wasn't able to.
have the physicians been contacting you at all? Have you been?
No, they haven't even been calling me about that stuff. I have to call them.
That I guess that I'd have to look into the chart to see if that is true or not. I haven't talked to. I know Dr. Mulroy, Dr. Pindy are both pretty good about talking to families. So
What was your name again?
I'm John
John? John what?
Blomberg.
Lombard? How do you spell that?
Blomberg.
Lombard?
Think of Mayor Bloomberg, but take out L.
Lombard. I appreciate you coming, speaking with me right now.
It's a unique situation, and it's kind of tricky because sometimes there's intricacies of healthcare that people may not totally know or understand.
Yeah.
So we're more than willing to explain them to you, but we also, in the same respect that you want from us, we expect that from you in dealing with, talking to nurses and physicians and employees of the hospital.
Yeah. The only reason that I started to get a little, I don't know if you say a little concerned, because it's not okay for them to be denying a right. I was just stating it clearly, and they're just like, honestly, they were being more disrespectful about it than I was.
Well, if there's any issues that you have had with certain staff members that you can absolutely, write us a letter or something explaining what they are so we can look into them.
Mm-hmm.
And we'd be more than willing, if there's issues we would want to know so that we can follow up with our staff and address the concerns that you may have. But that's something that kind of I would need some direction on, like, your experiences, so then I could investigate it on my end.